Welcome, everyone. My name is Aman Bajwa. I'm an associate professor at the University of Tennessee Health Science Center and a member of the AKINOW Basic Science Work Group. Thank you for joining today's AKINOW Journal Club event. This is the fifth in the series presented by ASN and the AKINOW Basic Science Work Group. Today's attendees include nephrologists, fellows, nurses, administrators, and technicians from across the globe. During today's Journal Club, Dr. Ronaldo Bellomo will discuss a randomized trial of intravenous amino acids for kidney protection. This article was published in the New England Journal of Medicine on June 12th, 2024. Here is our agenda. Following the presentations by Dr. Bellomo, Dr. Mark Rakusa and I will lead a discussion based on questions which you, the audience, submitted during the registration process. Please keep your chat panel open throughout today's Journal Club so that we may have interactive discussions. Please note a few housekeeping items for today's Journal Club. In acknowledgement of the changing nature of medical information and practice, please note this disclaimer. Here are the disclosures for all the individuals participating in today's Journal Club. Let's get started. To begin, it's my very great pleasure to introduce Dr. Ronaldo Bellomo, who was the senior author for the article we're discussing today. Dr. Bellomo is a professor of intensive care medicine at University of Melbourne, professor of medicine, Monash University, co-director of the Australian and New Zealand Intensive Care Research Centre, director of intensive care research at Austin Hospital, and editor-in-chief of critical care and resuscitation. He has triple training in nephrology, pulmonology, and critical care medicine, and longstanding interest in acute kidney injury. He has co-authored more than 1,900 PubMed citation publications, including 26 in the New England Journal of Medicine, and he is the most published biomedical investigator in the history of Australian medicine, and the most published intensive care investigator in the world. But, well, without further ado, I introduce you to Dr. Bellomo. Dr. Bellomo, please begin whenever you like.
Thank you very much, Amandeep. I appreciate the kind introduction. Let's see if we can get the slides to move along. Very good. And so today I'm going to talk about the role of amino acids to protect the kidney from acute kidney injury in cardiac surgery. There are a few key concepts that I would like to introduce first in order to understand the protection trial. First of all, acute kidney injury after cardiac surgery is very common. We think it's around 1/3 of patients having cardiopulmonary bypass. Second, cardiopulmonary bypass causes serious injury to the kidney in ways that we don't fully yet understand and are just beginning to appreciate. Fourth concept is renal tissue hypoxia, especially medullary hypoxia, is a likely driving force for such injury. The next concept is that, like other organs, the kidney can increase its function and its blood flow through a phenomenon called renal functional reserve. And finally, amino acid infusion is a very powerful way of recruiting renal functional reserve. So before I discuss protection, I want to discuss some recent work that we've done, or a paper which is currently under review, to understand in an animal model of cardiopulmonary bypass what might be happening to the kidney. In this model, in a large animal, the sheep, we prepare the animal with a couple of surgical interventions, about a month or so before the cardiopulmonary bypass experiment and insert transit time flow probes and oximetric probes into the medulla and the cortex of the kidney in order to monitor renal oxygenation. Then on the day of the experiment, we place the animal on cardiopulmonary bypass for 2 hours, and then we recover the animal. Now, other people have done immediate recovery and immediate assessment after the operation, but we are the first ones to be able to recover the animals and keep them alive for studying up to a month after the operation. When you put the animal on cardiopulmonary bypass, you induce renal tissue hypoxia. The medulla shows a significant deoxygenation. The cortex has a similar degree of deoxygenation, and renal blood flow decreases. And this continues up to 48 hours if you're looking at the immediate effects. It also changes the vascular conductance of the kidney, which is the inverse of resistance, decreases renal oxygen delivery, and leads to renal venous oxygen desaturation. These animals had renal vein catheters to sample the effluent from the kidney. This is up to 48 hours, and there is quite a body of data by other investigators that this happens, and it's consistent and recurrent. But what we were able to do is then study what happens as you go to 1 week, 2 weeks, 3 weeks, and 4 weeks. And what we found was extraordinary. There was persistent and quite dramatic oxygen desaturation of the medulla all the way to 4 weeks after exposure to cardiopulmonary bypass. It was cortical deoxygenation as well, and it was persistent, prolonged, decreased oxygen delivery all the way to 4 weeks. Importantly, at 4 weeks, we euthanized the animals and we were able to look at their histology. The normal renal histology of the sheep is seen on A and B. When you look at C and D, you see that there is a very exuberant inflammatory infiltrate at 4 weeks in the sheep exposed to cardiopulmonary bypass. When you look at E and F, you see there is also significant fibrosis that's developed during these 4 weeks. When you look at G and H, you see that at 4 weeks, the kidneys show hyaline casts and tubular cell casts in the histological slides, indicating the cardiopulmonary bypass at 4 weeks is associated with deoxia of the medulla and the cortex and tissue injury. Therefore, this is a serious illness and needs to be addressed. Let me talk about the concept of renal functional reserve. Its first detailed description was from Juan Bosch from Washington University. This is now 40 years ago. Since then, there have been more than 150 publications in human volunteers and in animals showing that the administration of a protein load or of intravenous amino acids leads to a surge in GFR as demonstrated by creatinine and inulin clearance. This is presumably a response to the ammonia load generated by protein intake and the need to then deal with the urea load that follows the metabolism of ammonia. So kidneys have a functional reserve like the lungs and the heart and the muscles, and they increase their filtration from baseline in response to this kind of stimulation. And this increase can be very substantial, up to 40% of GFR. What are the mechanisms that lead to such an increase? Well, people have been able to document an increase in nitric oxide synthase activity, in the release of prostaglandins into the renal circulation, a decrease in the tubular-glomerular feedback, all of which leads to afferent arteriolar vasodilatation, which leads to increased renal blood flow, increased glomerular flow, and increased GFR. We have recently shown for the first time that in the sheep when we give amino acids, there is not only an increase in renal oxygen delivery that would come from vasodilatation and a substantial increase in glomerular filtration rate of 45%, but that this is accompanied by renal cortical tissue PO2 increases and medullary PO2 increases. Therefore, the increase in GFR that comes with amino acid administration is accompanied by an increase in renal oxygenation. Is there any data in the literature preceding the protection trial to suggest that amino acids are A, potentially effective, and B, safe? This is now from 50 years ago in 1973. It's a study which was comparing TPN using what was then a standard preparation with glucose, or TPN at adding the amino acid preparation to it. And what you can see there, the creatinine fell faster with amino acid administration, and there was a change in survival and hospital mortality, all in favor of adding amino acids to the treatment of these patients. About 10 years ago, we conducted a randomized controlled trial in critically ill patients to study whether the administration of amino acids would affect renal function in this population. And we demonstrated that even in critically ill patients, the administration of amino acids were able to recruit renal functional reserve, as demonstrated by an increase in GFR using creatinine measurements, as well as cystatin C measurements, and an increase in urinary output. Of interest, in a post hoc study of this cohort of patients, looking at those that had normal renal function at randomization, there was a signal for increased survival, decreased mortality in the population that was treated with amino acids, providing evidence of potential benefit, but also evidence of likely safety of this intervention. We then reasoned that the population we wanted to target was the population of cardiac surgery patients, because in those patients, the insult and the timing of it would be known, and we would be able to intervene prophylactically and thereby prevent injury before it happens. So we conducted a pilot investigation, which was conducted in 69 patients. And what we found was that the duration of acute kidney injury and the urinary output were affected in a positive way by the administration of amino acids. Do we have any data that in cardiac surgery patients, the administration of amino acids can affect blood flow and GFR? And the answer is yes. This is a study conducted in Sweden 20 years ago in patients having cardiac surgery. They were allocated to amino acids or usual care, and the administration of amino acids in these patients after cardiac surgery was associated with a 58% increase in renal blood flow and a 53% increase in GFR. So in these patients, again, there is an effect for recruitment of renal functional reserve. Importantly, when this happened, the increase in renal blood flow appeared to unmask inadequate oxygen supply by increasing the oxygen uptake by the kidney. So we had a large body of data, experimental and in humans, preclinical and clinical, randomized, controlled, or observational, to indicate that amino acids would have a very strong chance of being able to recruit renal functional reserve and increase GFR. And therefore, we proceeded to design a randomized controlled trial, which we felt would have suitable power to test the hypothesis that in cardiac surgery patients, the prophylactic administration of amino acids would decrease the incidence of acute kidney injury. This is the protection trial. And as I said before, this is a big deal. About 2 million patients have cardiac surgery bypass in the world every year. 30% are complicated by AKI, and that carries a significant cost of morbidity and mortality and financial costs. We believe that this syndrome is multifactorial, and we all understand that, but we also believe that decreased perfusion to the kidney by decreased renal blood flow with renal medullary hypoxia is a central element in the loss of glomerular filtration rate. We published the protocol of the protection trial prior to data lock and data analysis, as is convention. And we began recruitment in 2019. And this was just a few months before COVID-19 hit the world and hit Europe very hard. And you can see the recruitment was essentially suspended until 2020. And thereafter, it was quite brisk and was able to get us to the completion of the trial in 2024. And we published that in the New England Journal of Medicine. The inclusion criteria were adult patients, pump surgery, and expected to stay until the next day. We excluded people that were already on dialysis, that had very low GFR, had a kidney transplant, were incredibly ill, expected not to survive. They'd been previously randomized to the study, had severe liver disease, and other obvious exclusion criteria. The population that we wanted to study was 3,500 in size. The patients were randomized to either have placebo or a continuous infusion of a balanced mixture of amino acids at 2 grams per kilogram per day of ideal body weight, or to a maximum of 100 grams a day. The treatment would start before the operation in the operating room after insertion of central venous access, and was given for 72 hours from the initiation of the infusion or until the start of renal replacement therapy or until ICU discharge, whichever of these would occur first. The preparation of amino acids that was used is commercially available preparation called isoputarbine 10%, produced by Baxter in Europe. And you can see the composition of amino acids there. And I have particularly underlined the arginine and glycine content because experimental preclinical data suggests that arginine and glycine are central to the development of vasodilatation and the recruitment of renal functional reserve. We use the creatinine criteria for the KDIGO creatinine criteria for the definition of AKI, as all of you will be familiar with. We did not use urinary output because there are massive confounders generated by the pump prime and the polyuria that follows that, and because most patients would not have a urinary catheter after 2 days of their operation, and we would not be able to collect data to 7 days. We also collected secondary outcomes, as you would expect, related to renal replacement therapy, ICU and hospital length of stay, mechanical ventilation, and mortality. The trial intervention was delivered as a continuous infusion. As you can see, the rate was 40 mils an hour. The median duration of the infusion was 30 hours, and the median dose of the fluid that was given was 1.26 liters. The bottles are displayed there, so about 2.5 bottles on average to each patient. 73% of patients had their infusion stopped at ICU discharge, and only about a fifth of patients received the infusion up to 3 days. This is a description of the kind of patients we were treating. The age group is very similar to what we see in the Western world. The sex distribution is very similar to what we see in the Western world, and the preoperative creatinine is similar to what we see in the Western world. The population was neatly divided into patients having coronary artery surgery, mitral valve surgery, or aortic valve surgery, with about 1 in 15 having aortic arch surgery or other surgeries. The ejection fraction was preserved on average in the population we studied, but about 1 in 5 patients had significant heart failure before the operation. The median duration of cardiopulmonary bypass was 1.5 hours. A lot of patients receive vasoactive or inotropic drugs, as you can see listed there, and the median blood pressure in the morning of each day of observation was supported and maintained at an acceptable level. The primary outcome of acute kidney injury, according to creatinine criteria, occurred in 26.9% of the amino acid group patients versus 31.7% of the placebo group, for a relative risk of 0.85 and a P of 0.002 in favor of amino acid administration. More importantly for us, there was an even stronger signal for stage 3 AKI, with a decrease of from 3% of patients to 1.6% of patients, and a relative risk of 0.56, or a 44% reduction in risk with the administration of amino acids. We had 3 planned subgroups that we thought might behave differently in relation to this intervention. And you can see there that, in fact, according to age, the presence of heart failure or creatinine clearance less than 60 mL per minute, it appeared that the effect of amino acid was consistent across these different groups. The secondary outcomes of renal replacement therapy was affected by a 27% relative risk decrease, which did not achieve significance because of the limited number of patients experiencing this secondary outcome. And this is the Kaplan-Meier representation of time to renal replacement therapy in the amino acid group versus the placebo group. The variety of other secondary outcomes we looked at, including the duration of renal replacement therapy, which was similar, which makes sense because the amino acids were stopped when renal replacement therapy was started. The mean duration of mechanical ventilation was the same. The mean duration of stay in intensive care was essentially the same, which is a tiny bit shorter with amino acids. But the mean duration of hospital stay was 1 day less in the amino acid group, even though this difference was not statistically significant, and there was no mortality difference between the groups, as you would expect. For the European system of cost in hospital, we looked at the potential cost of the intervention and potential cost savings of the intervention. And in this study, there were about 3,000 fewer ICU hours in the amino acid group and 146 fewer ICU days with amino acids. And also there was a decrease in the number of hospital days. And so the total cost of ICU time and hospital day costs led to an estimation of an effect of a saving of about 500 euros per patient. We have since done a formal health economic evaluation of amino acid therapy with the School of Public Health at my university, looking at all the literature available for a meta-analysis of perioperative amino acid administration, looking at costing from Australia, China, Italy, United Kingdom, United States for post-operative care in these patients. And all of these scenarios point to a saving of money with the administration of amino acids, no matter where you are, whether you're in Australia or the United Kingdom or the United States. So it appears that this intervention has a benefit on kidney function and comes at decreased cost of post-operative care. What about safety? We collected data with specific adverse events in mind that would be particularly significant and important in cardiac surgery. You can see them listed there, from mechanical circulatory support to stroke or sepsis and need for reintubation. and you can see that there was no safety signal with amino acid therapy. So this is the visual abstract from the New England Journal of Medicine to summarize the study. 3,511 patients randomized. In hospital, AKI was decreased with amino acids by about 5% absolute decrease, which is a number needed to treat of 20. Stage 3 AKI was also decreased, and the use of renal replacement therapy was decreased as well, although not significant in terms of p-value. We have subsequently, as you do, gone on to look at the literature with a systematic review of perioperative administration of amino acids. There are 15 studies that can be assessed, and we can see there is a consistent signal that AKI is reduced with amino acid administration in the perioperative period, that AKI stage 3 is reduced with the administration of amino acids in the perioperative period, that the GFR in the studies that measure that is increased by about 7 or 8% in these patients, and the hospital length of stay is decreased by about 1 day, consistent with the protection trial. So let me conclude my presentation by saying that we now, and we've always known, but we understand more clearly from experimental models, that cardiopulmonary bypass causes serious injury to the kidney. Much of this injury appears to be related to renal hypoxia, which in the experimental models appears to be persistent and continue for up to a month, and appears to be associated with renal injury, with hyaline casts, cellular casts, and fibrosis and inflammation. The administration of amino acids recruits renal functional reserve. It increases renal blood flow and increases renal oxygenation. We have pilot studies of amino acids that have consistently shown renal benefits, as demonstrated in a meta-analysis. We've now conducted a large double-blind international multi-center randomized controlled trial of more than 3,500 patients, which has now shown a clear beneficial effect by decreasing the incidence of AKI and decreasing the incidence of AKI stage 3. These effects are supported by the meta-analysis that we've just presented to you and associated with a decreased cost of care. There appears to be a robust case for amino acid treatment of patients having cardiopulmonary bypass with the goal of preventing renal injury and decreasing the cost of post-operative care. Thank you very much for your attention.
All right. Thank you so much for that wonderful presentation, Dr. Bellomo, and that for those outstanding remarks. Now let us begin the discussion part of the Journal Club. I would like to welcome, and I'm delighted to introduce Dr. Akusa, who is the Division Chief and John C. Buchanan Distinguished Professor of Medicine and Nephrology at University of Virginia. His research interests include inflammation, fibrosis, and progression of kidney disease. Dr. Akusa is a member of the AKI Basic Work Group. Audience, please submit your questions through the Q&A option on your screen, and we'll get started with those questions now.
Let me just make a comment. Dr. Bellomo, thank you very much for taking part in this ASN Journal Club. We really appreciate your taking the time, and congratulations on a terrific study. Time and time again, you always seem to publish these very large randomized controlled trials in acute kidney injury and critical care. So thank you so much.
Thank you, Mark. Thank you, Mark. I appreciate those comments.
Well, while the questions are coming in, I'd like to start off by asking you a question. If the presumed protective effect of amino acid infusion was to enhance renal reserve, one would think that this would not be beneficial in patients with CKD that have no renal reserve. Yet your data suggests that whether the subjects have CKD or not, amino acid infusion was still protective. So I'd like your thoughts on whether this suggests that the protective effect of amino acid infusion could be due to other mechanisms other than renal reserve.
Yeah, this is a very important question, Mark. So the first comment is that in the trial, we had 808 patients with a creatinine clearance less than 60 mils per minute and eGFR in the CKD range. And we went all the way down, as you know, in the recruitment to 30 mils per minute. Those patients have been the subject of a secondary paper, which we have just had accepted for publication in anesthesiology, where we looked at the effect of amino acids on the incidence of AKI on CKD by dividing those patients to three groups, those with a eGFR between 50 and 60, 40 and 50, and 30 and 40. And we find exactly the same effect in all of those patients, which was a surprise to us because we reasoned, like you, that the renal function reserve of these patients would be minimal, and therefore the amino acids would not have had the effect in these patients that they might have in patients with preserved renal function. So you're quite right. This speaks to potentially different effects beyond the recruitment or renal functional reserve. But it also speaks to the fact that even though renal functional reserve may be quantitatively less in patients with CKD, as a proportion of their overall eGFR, it may actually be similar to those with normal renal function. Put it another way, the increase in GFR might be 3 or 4 mils per minute in somebody with an eGFR of 32 mils, but that's a 10% change, when in somebody with a GFR of 80, it may be 80 mils per minute, and the proportionality is maintained across these two groups of patients. In the CKD population from our trial, amino acids had a number needed to treat of 14 to prevent AKI on CKD. These patients are crucial to us, and now we got ethics approval to follow them up to see what their eGFR is now, because our first patient was randomized now almost 5 years ago. So we have the ability to see if there is a long-term follow-up benefit of preventing AKI on CKD after cardiopulmonary bypass.
Interesting. Thank you.
Okay, I will go ahead and start with the first question in the chat. Everybody agrees that was a wonderful presentation. Thank you. Is this temporary improvement in GFR, or is this intervention also help with tubules? Did you have any evidence if proximal tubules were less injured in the intervention arm?
Yeah, so that's a really good question. And indeed, it's a question that was asked by the reviewers in the New England Journal of Medicine review. And the answer, no, we don't. And so we do not have the ability to know whether there was any potential signal of tubular injury. However, I should say to the group that's listening here is that we've published our study in sheep, where if you give amino acids, you actually increase medullary oxygenation by 25%. So this intervention increases GFR and increases medullary oxygenation. So it seems unlikely, although it is still possible, that it would lead to injury to the tubules. But we're acutely aware of this, and we're currently conducting a trial where we're measuring biomarkers of tubular injury in a before and after interventional study of amino acids to see if there is indeed a signal of tubular injury.
Along those lines, there is a question that why cystatin C was not considered as a marker for injury?
So cystatin C is a tricky thing in cardiac surgery patients. Many cardiac surgical programs give steroids to decrease the inflammatory response to bypass, and steroids have a profound influence on cystatin C. And the second thing is the actual cost of measuring cystatin C in a 3,500 patients trial. So for those reasons, we didn't pursue that measurement, but I think it's real and it's important. And again, we're now addressing that in a subsequent study, which we're conducting at the moment.
Yeah. I think we have partially answered this question. In the chat, there was a question that were there any patients with stage 3 or 4 CKD in the treatment arm? And I believe your next manuscript.
That's right.
That question.
Yeah, it will be out in anesthesia. It's already been accepted. It'll be now out in anesthesiology, I don't know, next week or 2 weeks. If you keep an eye on that, it will be there. We'll have a detailed discussion of such patients.
Well, we'll look forward to that. So next, the question is, why did it take so many years to show benefits of amino acid infusion for AKI?
You know, getting to the point of being able to conduct a large pivotal trial takes an incredible amount of time, resources, coordination, you know, and I think we had signals, and we've had signals repeatedly in the literature by getting the resources, getting the structure, getting the centers, organizing and delivering a trial of 3,500 patients is an extraordinary enterprise. And on average takes about 7 or 8 years to prepare, obtain funding, execute, and analyze. It's a lot of work.
Okay. Dr. Kumar wants to know, or he wants to be for you to remind him that what was the proportion of patients recruited in the USA and UK?
There were no patients recruited in the US or the UK. This study was conducted in Central Europe and in Asia. So there were centers from Italy, centers from Croatia, and centers from Singapore, but no other centers from Europe and no centers from the UK or USA. And I am currently working with 3 different centers in the USA to see if they can conduct some work in the United States to see whether the signal that we saw can be replicated in the USA clinical environment.
Okay. I think the next question is somewhat interesting since creatinine was used as a marker for detecting injury. And the question, it reads that arginine and glycine aminotransferase, AGAT, catalyzes the first step in creatine biosynthesis within the kidney. Could amino acid infusion impact creatine synthesis, thereby affecting creatinine formation and excretion?
So, yeah, I think that's a very legitimate question. And it was raised by the reviewers of the article in the New England. And it is possible. As you said, we didn't measure cystatin C, but we have data from our previous paper in 2015 in critically ill patients which I presented a slide of, where we studied 474 patients with amino acids, and we saw an increase in GFR, a significant decrease in creatinine, and we also measured cystatin C, and we saw the equivalent decrease in cystatin C consistent with the same effect in GFR. So we got a body of data, not in people with cardiopulmonary bypass, but in people receiving amino acids just the same that are critically ill, showing that you get the same signal of the same magnitude if you measure cystatin C. And then with the amino acid literature, which is now more than 150 experimental and human volunteer studies, even when you measure inulin clearance, as I showed in the slide before, there is a change in GFR with amino acids, which is independent of creatinine clearance. So on the balance of the information available, although we cannot exclude a component of our signal derived by the effect of arginine on creatinine synthesis, we probably believe this is a real GFR effect because of that previous data that we have on cystatin C and on inulin clearance.
Okay. Next, the question is, what is the right time to start the amino acid infusions?
Again, this is really important. We chose to start the amino acid infusion before the beginning of cardiopulmonary bypass because of the logic that if we had the infusion before the injury, this would be important. And because of all the experimental data that I showed you of the effects of cardiopulmonary bypass on the kidney. However, it is possible that an intervention that comes after cardiopulmonary bypass and possibly leads to a loading dose of amino acids for a rapid rescue and maintenance might have similar effects. This kind of study needs to be conducted, but at the moment, I would advise people that administration before the injury is probably the most logical approach.
Since not all amino acids are created equally, and I know you showed the different amino acids that went in the cocktail that was infused, does it matter what the composition is past what you already showed?
It probably matters to a degree. We have experimental data that suggests that arginine and glycine are major drivers of the renal vasodilatation, increased renal blood flow. We have data that suggests that branch chain amino acids are not effective. They don't have a major contribution to the increase in GFR, but there isn't a proprietary preparation that is able to deliver a select choice of amino acids that we could use. So if you're conducting a trial and you want to achieve something that might lead to improvement on a global scale, you need to use a preparation that is widely available, what is commonly available across the world. And so you do have to resort to what preparations are available at 10% amino acid concentration, and such preparations are usually non-selective and a balanced mixture of amino acids.
Okay, I'm not sure if I missed it. Was there information on changes in cardiac output in patients receiving amino acid infusion?
Good question. Yeah, that's a good question. We do not have such data. It's important that people should realize that amino acids probably have effects that go deeper than what I've just presented to you. We got very strong literature in the anesthesia literature that amino acids stop shivering in the post-operative period. And we got very good control data in the anesthesia literature that they decrease hypothermia after elective major surgery. Mm-hmm. So amino acids appear to have an effect on thermoregulation. And what other effects they may have remains unknown, but we did not collect hemodynamic data.
Thank you. The last question that I see is, does the severity of AKI change the outcomes of the benefits that you see with amino acid infusion?
So the severity of AKI is obviously a post-randomization event, and so it creates a bias. So it's very difficult to make that judgment. But obviously, we think that some of the decrease in the duration of hospital stay is primarily driven by a decrease in those patients that have very significant and major creatinine rises, like stage 3, where the clinicians may be more likely to keep the patient in hospital for longer, either because they need renal replacement therapy or because there is concern about wanting to see evidence of renal recovery. And we think that's likely to contribute, but this is a post hoc event, and so you can't really draw conclusions about it.
Okay. I guess I'll let Mark ask if he has any questions.
Yeah, I just wanted to go back to that the question about the cardiac output and metabolism, because there's a question in the chat box that just disappeared. Oh, here it is. So beyond the effects of amino acid infusion on renal hemodynamics, do you speculate that amino acids which are metabolized by the proximal tubules, and the resulting increase in oxygen consumption could actually exacerbate the post-cardiopulmonary bypass hypoxia?
Look, as I said, that's possible, and the only data that we have about tissue oxygenation is from the sheep experiments that we have conducted, which I presented at the beginning, one of my slides, showing that amino acids improve medullary oxygenation in the sheep by about 25%. So we do not have evidence that medullary or cortical hypoxia is induced by the increase in GFR that amino acids lead to. But in human beings, of course, it's really not possible to monitor what might be happening. And so we can only derive conclusions and speculate on the basis of animal studies.
The protective effect of amino acid infusion seems to be due to decrease or vasodilation of the afferent arteriole. Since there is widespread use of certain drugs in this population, like SGLT2 inhibitors, do you think that this would negate the effects of protective effects of amino acid infusion?
Yeah, that's a really cool question. And we do not have data to be able to speculate around that. Typically, SGLT2 inhibitors are stopped prior to cardiac surgery because of concerns about non-diabetic normal glycemic ketoacidosis. And so most of the patients would not have been exposed to these agents and were unable to comment on the interaction.
So the question is that in the sheep model, the cortical and medullary hypoxia was evident after 4 weeks rather than recovery. And why do you think that is?
So this is something that we have no real understanding of. And, there is hypoxia immediately, but it continues and appears to get even worse as time goes by. And from our point of view, we have to ask questions about, is this an inflammatory response which leads to dysfunction of the microcirculation in the interstitium? Does the fibrosis that develops after the inflammation of cardiopulmonary bypass impede oxygenation in the interstitium and thereby cause the signal that we see? There are all these events, and it's really, unless you're able to manipulate one specific event versus another event, we cannot separate the mechanisms of why that would happen. But it seems reasonable to argue that if there is so much inflammation and fibrosis, that would contribute in some way to the deoxygenation of the medulla and the cortex in these experimental animals.
So in the same experimental animals, did you examine any capillary rarefaction?
No, we didn't. We didn't.
That was the next question.
Sure.
All right. So based on the study results, are you planning to routinely use amino acid infusion in your high-risk patients to protect against AKI?
No, I am planning to conduct, and I'm organizing it right now, I'm trying to conduct a phase 4 study, what we call translation of research into practice study. I have organized here in Australia a cohort of 10 cardiac surgery centers, and what we have that have very sophisticated, detailed data on their cardiac surgery patients, everyone for the last 2 or 3 years. And then next year, we're going to start giving everyone amino acids. And what we're going to see is whether there is a change in the incidence of AKI over the year that follows the introduction of amino acids. That should allow us to have about 3,000 patients or so treated with amino acids that can be compared to about 9,000 patients for the 3 years before. And we plan to do a segmented analysis to see if the incidence of AKI, for example, was 30%, 29%, 31%, and then down to 24%. If we see that, then we feel we'll have very clear and robust evidence that the introduction of amino acids is a powerful, robust, reproducible, widely applicable biological event. And then if that information supports our contention, and it may not, if it does, then I will answer to you, yes. But right now, my answer is no.
Okay.
I'm not ready yet. We need to do more.
All right. So this may be a naive question, but are there any settings where amino acid infusion that result in increase in GFR and better blood flow detrimental for kidney health?
It's quite possible. At the moment, we've got 2 studies that are about to start. One is in patients with septic acute kidney injury, where we're going to take patients with early septic acute kidney injury and randomly allocate them to placebo or amino acids to see if in that setting amino acids are going to be able to rescue GFR and diminish the risk of stage 3 AKI. And in that population, we'll be measuring biomarkers of renal injury, measuring cystatin C and doing more sophisticated assessments of renal function. We are about to conduct a study in patients having liver transplantation. It's a unique population with a very high risk of ischemia to the kidneys and also exposed to drugs like tacrolimus or cyclosporin A that induce renal vasoconstriction. So that's another important population. And then finally, we've got an ethics submission in the Italian context with my colleagues in Milan to look at patients having renal transplantation now to see if we can decrease the incidence of delayed graft function. So the data is going to accrue, I think, in the next 3 to 4 years, and we will be in a position to have a more global, detailed understanding whether there are patients where we shouldn't do it, and whether this is an effect that can be applied to rescue the kidneys from injury in different settings.
Thank you. Are there any questions, Dr. Akusa or Dr. Kumar, that you have? If not, yes?
No.
No? Okay. Well, on that note, I want to thank you for your time, Dr. Bellomo and Dr. Akusa, for your superb contribution and for providing invaluable information today. We also want to thank the audience for joining us today, and then letting us have this wonderful AKI Journal Club event. If you have additional questions, please contact ASN. On the behalf of American Society of Nephrology, our presenters, thank you for your joining us and participating in today's Journal Club. Have a wonderful day.